on the situation of health in the region of the Americas. We have shown much improvement in the last 50 years. And along these improvements, infant mortality and neonatal mortality have reduced. We have a lot of work that has been done and also facilitated by the Latin American Center of Perinatology, Women and Reproductive Health, CLAP, which is in the department that I direct, the Department of Family Health Promotion and the Life Course at the Pan American Health Organization here in Washington. And we have a birthday. CLAP is having its 50th birthday. It has played a key role since 1970, generating, communicating evidence, training health professionals, providing technical cooperation, and strengthen institutional capacities in these countries. This is the context of this very exciting seminar that we are starting, where we are going to see some of the significant challenges that still remain. So the first thing that we are going to do is that for this celebration of CLAP, they have actually put together a series of videos. And the one we are going to present now is CLAP at present, and we will have a surprise at the end of the session. So if we could start with the first video. Thank you.
Siempre fue un sueño trabajar en un lugar donde se puedan hacer cosas que marquen la vida de las personas. Y creo que el CLAP marca históricamente la vida de muchas mujeres y de muchos recién nacidos.
Durante estos 50 años, CLAP ha atravesado distintas etapas, acompañando hasta el presente las necesidades de la región para mejorar la salud de las mujeres, las madres y los recién nacidos.
Se fue migrando desde la investigación básica, la investigación esencial, a la investigación en salud pública y a la implementación de programas en salud pública.
En ese camino es muy importante la acción histórica del CLAP en el desarrollo de los materiales de capacitación, los instrumentos para la atención.
Durante un periodo de tiempo el CLAP se dedicó específicamente a hacer medicina basada en evidencia. Producíamos publicaciones para que le llegara a la gente en su propio idioma con las cosas más actuales.
Las investigaciones del CLAP permiten desarrollar buenas prácticas basadas en la evidencia que luego se trasladan a los países de la región de las Américas.
Lo que tratamos de hacer es encontrar a los docentes de medicina, de enfermería, de partería, para que sean los primeros que se entrenen.
CLAP ha expandido el CIP no solamente en términos geográficos, sino también se ha expandido a diferentes subgrupos, como por ejemplo recientemente se ha creado el CIP COVID-19.
La OPS siempre trabaja para lograr la salud universal. Este sueño no se alcanzará sin contemplar las necesidades de las mujeres, las embarazadas y los recién nacidos. Mediante la labor del CLAP, la OPS trabaja para que este sueño se haga realidad.
Duérmete mi sol, duérmete pedazo de mi corazón.
The next item in our agenda is I'm going to introduce a very important special person. It's Marilu Valdez. She is the PAHO WHO Deputy Director. We are very happy that Lu has found the time to do opening remarks. Let me tell you a little bit about her. She's a US citizen, and former official of the US Food and Drug Administration, FDA, became the deputy director of our organization in February 2020. So she's very new in place. We are very happy to have her. The second highest post at WHO, WHO, with a portfolio that includes to serve the secretary of the governing bodies of the organization, including the Pan American Sanitary Conference, the directing council, and the executive committee. She oversees the official relations with the governments of Canada, the United States, and Puerto Rico, serves as a member of the organization's executive management, and has direct oversight of the departments of planning and budget, external relations, partnerships and resource mobilization, communications, as well as the offices of the governing bodies and equity, gender, and cultural diversity. Ms. Valdez has a Bachelor of Science degree in biology from the University of Texas in El Paso in 1986, and a Master's of Science degree in management from the University of Maryland in 1998. In 2003, Ms. Valdez was appointed Deputy Director of the Office of Global Health Affairs in the US Department of Health and Human Services. In 2009, she joined the Food and Drug Administration as Associate Commissioner for International Programs, and since March 2019, she has been serving as the FDA's Associate Commissioner for Diplomacy and Partnership within the governing global policy and strategy. Ms. Valdez has been a member of the US government delegation for governing bodies of multilateral organizations, including the World Health Organization's Executive Board and the World Health Assembly, and executive boards of the United Nations Children's Fund, UNICEF, and the Perinatal Health Organization, among others. It is a pleasure for me to introduce Dr. Marilu Valdez to give us some welcoming remarks. Marilu, the floor is yours.
Thank you, Andres, for that kind introduction, and good morning, everyone. It is such a privilege to be with you here today. Let me start by thanking our speakers, Doctors Raul Gupta, Linda Adair, and Cesar Victora. And of course, a special shout out to Dr. Suzanne Jacobs Soroya, Director of CLAP, and our own Andres de Francisco, Director of PAHO's Family Health Promotion and Life Course Department. Like Andres said, please join us in recognizing the 50th anniversary of the Latin American Center for Perinatology, Women's Health, and Reproductive Health of the Pan American Health Organization. What an incredible history of accomplishments for women and children. Newborn health issues and stillborns have been defined as part of that unfinished agenda of the UN Millennium Development Goals for Women and Children's Health, and are part of the Sustainable Development Goal 3.2. A newborn death or a stillborn is a tragedy without bounds for families and communities around the world. Stillborns were also included in the UN Global Strategy for Women, Children, and Adolescent Health 2016-2030. And following that UN strategy, PAHO member states approved a plan of action for women's, children's, and adolescent health 2018-2030. This plan of action is based on the concepts of survive, thrive, and transform. Let us apply these concepts to the life course. So first, survive. This relates to ending preventable deaths. More than 80% of all newborn deaths result from preventable and treatable conditions. Complications due to prematurity, birth defects, intrapartum related death, and neonatal infections. Thrive. We must ensure health and well-being by ending all forms of malnutrition and addressing the nutritional needs of children, adolescents, and pregnant and lactating women. To thrive, we must work together to achieve universal health coverage for all these populations, and that includes financial risk protection and access to quality and safe essential services, medicines, and vaccines. Transform. Cost-effective solutions exist for the primary causes of neonatal death and disability. To achieve universal health coverage, we need innovation, people-centered care, locally designed technologies, and parent empowerment and partnership. Social norms also need to be transformed, as neonatal mortality should not be seen as an inevitable outcome. In 2019, the neonatal mortality rate in the Americas was as high as 7.7 per 1,000 live births, corresponding to more than 113,000 neonatal deaths, with high variation between our countries. Thus, to deliver on the promise of survive, thrive, and transform, there is much work to be done. Strengthening and investing in care during labor, birth, and the first days and weeks of life will enhance quality. An equity lens and community participation for maternal and newborn care is also key, as the poorest 20% of the population in most countries significantly lag behind, and we must renew actions to advance equity. We must address vulnerability. Women, newborn, and children are among the most vulnerable in any community. Integrated people-centered care puts people and communities at the center of health systems and empowers them to take charge of their own health. Care for small and sick newborns requires a family-centered approach. Investments in research, technologies, and innovations are needed. Investing in research and development is critical to support the design, testing, and scale up of new and innovative care approaches. Applying a life course lens is key. Transforming care for every small and sick newborn is the path to achieve the 2030 Agenda goals. With appropriate action, every newborn can and will survive and thrive as future productive members of society. We must catalyze political leadership. It takes a multi-sector, multifaceted approach to improve newborn outcomes by incorporating a health lens into decisions, policies, and actions across sectors. A health in all policy perspective is central for planning and implementing interventions and requires a wide range of stakeholders for success and sustainability. Now, while there is still much work to be done, we also have much to celebrate. We recognize the contributions of our non-state actors in official relations. In collaboration with PAHO, these entities support PAHO's strategic plan and help advance public health in the Americas. The March of Dimes is a true global and regional pioneer and champion for newborn health. The public health and research leadership of the collaborating centers on health equity monitoring at the Federal University of Pelotas and the University of North Carolina is also notable. And again, PAHO's own Latin America Center for Perinatology, Women's Health, and Reproductive Health has provided technical excellence to strengthen and improve healthcare for women, mothers, and newborns in the countries of the Americas. We not only want to recognize CLAP's 50th anniversary of working tirelessly to reduce maternal and neonatal mortality through strong evidence in science, but we also want to applaud CLAP's leadership, vision, and commitment to maternal, child, and infant health. Now, as our region continues to mitigate the effects and the impacts of COVID-19, we must safeguard, now more than ever, the decades of progress on maternal and child health and well-being. We know that the first years of a child's life sets the stage for all future growth. The earliest years of life are so critical in terms of nutrition, protection, and stimulation for healthy cognitive development. We must protect the progress we helped to create. The continuity of essential services and sufficient and sustainable resources for reproductive, maternal, newborn, child, and adolescent health are absolute prerequisites as nations strengthen their resiliency of their health systems and recover their economies, all while mitigating the impact of COVID-19. Protecting the health and well-being of mothers, children, newborns, and adolescents during the pandemic is vital so that families, communities, and countries can build back stronger and not only survive, but thrive and transform. The strength and the resiliency of our nations depend on this. Thank you again, and I wish you much success in this seminar. Thank you. Over to you, Andres.
Thank you very much, Marilu, for these wonderful words of introduction that shows the understanding that you have of the work that is being done in CLAP and in FPL. So we really welcome these comments. Thank you so much. Now, without any further ado, I'm going to pass the floor to Dr. Pablo Duran. Pablo is the regional advisor on perinatal health at CLAP in Uruguay, which has the regional perspective on the theme. He's going to be leading the presentations and the discussions. That means the next segment of this webinar. And we are looking forward to this. So, Pablo, the floor is yours.
Muchas gracias, Andrés, y tengan ustedes un muy buen día y una muy buena tarde desde Montevideo, desde el Centro Latinoamericano de Perinatología.
Greeting all of you from CLAP Montevideo. We welcome you to this seminar. It is an honor for me to introduce the speakers who are with us here and who honor us today with their presence and their experience in the topics we will address. First of all, we have Dr. Rahul Gupta, our first speaker. He studied in China. He obtained a master's in public health at the University of Alabama, and also a management and administration at the LSE. He's a specialist in internal medicine and preventive medicine, and assistant professor in the Policy Management and Leadership Department of the Public Health School of the West Virginia University. He is Senior Vice President and Health Medical Director. He will refer to the prematurity burden in the Americas. Secondly, we have Linda Adera, professor on the Department of Nutrition, the Gillings School of Global Public Health at University of North Carolina. She's a biological anthropologist. Most of her work relates to the first 1,000 days, the time period from conception through the first 2 years of a child's life. And she has directed the longitudinal health and nutrition survey at Cebu, the Philippines, since 1990, a birth cohort study, which is part of an international collaboration called Cohort, that has developed a series of important insights about the early origins of obesity and cardiometabolic diseases in low and middle income countries.
Also works in Malawi and Rwanda and is focused on the prevention of mother-to-child transmission of HIV, breastfeeding, complementary feeding influence, infant growth, and survival. Her work in South Africa explores how maternal health affects infant pre and early postnatal growth. Professor Adair will be talking about the implications of the small size at birth and the impact on health throughout the life course. And after that, I'd like to introduce Dr. Cesar Victora. He is Emeritus Professor of Epidemiology at the Federal University of Pelotas in Brazil since 1977. He obtained a medical doctorate degree from the Federal University of Rio Grande do Sul in Brazil, with a PhD in healthcare epidemiology from the London School of Hygiene and Tropical Medicine. Has conducted extensive research work in the state of Rio Grande in Brazil, and has worked as a researcher and consultant in more than 40 countries, has been an advisor to the World Health Organization, UNICEF, Pan American Health Organization, and his areas of research include maternal and child health and nutrition, breastfeeding, birth cohorts, social inequalities, and evaluation of health services. He holds honor titles and honorary appointments at the universities of Harvard, Johns Hopkins, Oxford, and London, and sits on the editorial board of several journals. Was president of the International Epidemiological Association in 2017. He was honored with Canada Gairdner Global Health Award, and in 2018, he was given the Abram Horwitz Award from the Pan American Health Organization, and he will be talking about generalized inequality as a threat to the future of children, boys and girls, their impact in the short and long term. And so without further ado, let me give the floor to our first speaker, Dr. Rahul Gupta. Please, Dr. Gupta.
Hello, and thank you. I want to, first of all, start with thanking PAHO and CLAP for having us here to have this privilege and honor. Also want to thank you, Dr. Duran, as well as Dr. Dee Francisco. And I additionally want to thank our panelists, as Dr. Linda Adair, Dr. Cesar Victora, as well as Dr. Marilu Valdez, for those wonderful remarks. And thanks for all of you to be able to share with us and be involved in this discussion. I'm going to share some slides, so I'm going to pull them up right now. Hopefully you all can see this. We're going to go in a presentation mode. So we really want to talk about the burden of prematurity and adverse conditions at birth. Want to focus quickly this morning on the burden, but also potential targets of intervention, and share some prospective solutions that we think at March of Dimes may have value for the Americas and perhaps across the globe. So March of Dimes has had a over 80-year legacy from being founded by a sitting president, Franklin Roosevelt, helping with polio, all the way to achieving remarkable success in perinatal health, mobilizing communities, folic acid, birth defects, and now we're focusing on addressing the inequities that exist in preventing us from having healthy moms and strong babies. We believe that our long-term agenda should look like a house. For all of us, our home is important. So we should have the goal of achieving that maternal and infant health and eliminating inequities, but with a focus on equity as a lens. We should have indicators, but the 4 pillars are really access, the health of the individual, health of the community. It's also equity lens for unequal treatments across our populations in the world, and then disrupting lifelong economic insecurity, creating safe, healthy environment and supportive communities. We do think that we are right now engaged in particular strategies to develop around science, to develop around equity, and certainly develop around community. And data. So we're working on these partnerships and programs. We do think that this is a very important piece of the puzzle. In the global context, Dr. Valdez shared some of the numbers. I will share some more. We know clearly that infectious disease remain the leading causes of death among children under 5. We know the millions of deaths and complications that occur. We also know that it's a challenge. We see, if you look at the newborn deaths, predominantly preterm birth complications and interpartum related complications contribute to a lot of those. There have been a number of efforts, as Dr. Valdez pointed out, that March Dimes and our partners have been engaged in, along with World Health Organization, UNICEF, and they've been important in the past, and it's important to continue that momentum. Certainly, the Born Too Soon report was a calling for global action on preterm birth. So let's look at the burden of preterm births. So if you look across the globe, clearly we have a challenge. We know that obviously there are areas across the world which have numbers that are much worse, from Bangladesh to almost 20% preterm birth. That's 1 in 5 babies being born with preterm. We know that the numbers are also more in those countries, especially in China and India, that have a larger population. But surprisingly, we also see higher numbers in, United States, Brazil, and while the rate is perhaps much more in countries like Colombia. So when we come obviously to the Americas, we see the rate of almost 15% in Colombia to low as 6% in Cuba, and we mentioned Brazil. So the important part is that you can see on the left side that the world rates and our rates in Latin America and the Caribbeans, but they're rising. They're rising faster than the world rates. The world rates have been more or less stagnant, but the rates across Latin America is going up. And it's important to recognize that in order to address it. This slide shows you what is happening in the United States. Each year, March Dimes does a report card where we grade every state and top 100 cities from A to F. So in this report, the pink means F, fail. The D is the yellow, that means almost fail. That's a rate anywhere between 10 and 11.4, 10.4 to 11.4. And for pink, it's over 11.5. And the C, which is the average country score, is 9.3 to 10.3. So you can see that we have now, along with Puerto Rico, a number of states that have total of 7 that have a failing grade. And of course, in the South, where we have more issues with access, because many of these states have not expanded access to care through Medicaid. We have high rates amongst other challenges as well. But then in a large state like Texas, our rates are still not acceptable. So it's a challenge within the United States for preterm birth, and majority of these are late preterm. So now when we do this report card, we are looking at factors that define not just for the baby, like preterm and infant mortality, but also for the mother. So we're looking at race, ethnicity, but we're also looking at the social determinants, issues of poverty, issues of access, prenatal care. We're also looking at ability to have insurance and have insurance beyond birth of the baby to up to 1 year. We're looking at policies and those states who are looking to move those policies forward. So this is a very important piece of our work. We will be releasing the 2020 report card on November 16th. So it's literally about 3 weeks away. We hope you're interested in checking that out when it is released. So what are the potential targets of intervention? to address the targets of intervention, we have to know what's causing it. Where are the problems? So I want to share with you a very bold point of view, and then we'll follow that up with data. This is the bold point of view for us. This is how we look at this. So we believe that for a long time, we looked at infant health as one iceberg and maternal health as another iceberg. We never, for many, many years, didn't really look at the connection between the two. And they're indeed connected, because many of the causes that lead to poor infant health, including birth defects and preterm birth, majority, a good number of causes for infant mortality, are also existing in causes for maternal health. So poor maternal health leads to all these. But I think we're still not there yet fully, because we're only looking at the above the surface of water. So we're looking at chronic health conditions. We're looking at clinical causes that we know of. And we still are looking at a medical model to fix issues. But if you look underneath the surface of the water, you will see where a large volume of that iceberg resides. So it's very important to identify and address as targets, potential targets, these issues. They have to do with socioeconomic stability, poverty, environmental conditions, environmental toxins and exposures, racism, implicit bias, nutrition and lack thereof, lifestyle, habits, behaviors, substance use, drugs included, mental health, intimate partner violence, and access and quality of that care. So we can have access, but it may be poor quality. So these are just some of the various causes that we think are potential targets for intervention, because in the past we've only looked at above the surface water. So it's very important for us to identify that in our communities, which are more, which are less, and begin to address those. And when we do a literature review, we find very similar. Interesting part is we have historically only looked at the center. So if you look at preterm birth, you classify that as spontaneous preterm contractions, pre-rupture of membranes or PROM, and medically indicated. Now, if you start to go beyond that clinical and start to look at others, then we start to see the maternal and pregnancy characteristics. We see the assisted reproductive technologies like multiple births leading to preterm birth, one of the very important factors, short cervix, much mental health, smoking, alcohol, and drugs. But then you go further, you start to see nutrition, physical activity. And then you go further, you see maternal demographics like birth spacing. 30% of preterm birth in the United States have history of preterm birth. So if we had adequate spacing, we could help those people. Similarly, extremes of age, education, socioeconomic. So this is the same in literature we show in the iceberg slide. And then at the bottom, you see long working hours, night shifts, hard physical labor. All of these things, including the external and social environment, are impacting. And we have to understand that in order to address these through policies. We have recently also launched something called Maternity Care Desert Report. The red here shows counties that have no OB care, no hospitals providing OB care. There are 2.2 million women living in these areas in the United States, responsible for 150,000 births. And then there's another 5 million women almost living in the orange and yellow areas that you see that have limited care access, which is responsible for another 311,000 births. So we think that where you live should not, your zip code should not define the quality and the level of care you get. But the unfortunate fact is it does so just about everywhere in the world, including in the United States. But there are things, once we identify, we can do to address these. So the prospect is solutions. We must take action to improve outcomes. Our goals in Martyrdines are to end preventable maternal risks and death, as well as preterm birth and infant death. But we have to look through the lens of health equity, and bridge that gap, eliminate that gap. Our approach has been in these three categories. We lead and innovate through data analysis, forecasting, conducting research. I'll talk about that in a minute. Public policy that research informs consumer education. We mobilize action across the country in local and international partnerships and collaborations, public awareness campaigns, and advocating for good policies. And then we have health programs as well as training of professionals and individuals. So we think about it in a comprehensive way to address. And this is the arc of science. We, for a long time, have exclusively funded discovery. We believe that it is important to combine the discovery science that looks at very basic genetic, environmental, and other conditions of preterm birth and other aspects that helps build a foundational knowledge to help us translate that knowledge into practical science. So it helps the translational focus to occur, which involves both diagnostics and therapeutics. And then from translational, we move to the clinical and social sciences to better understand research outcomes at individual and population level, and be able to really do what we call implementation science. So to use what we know and make sure it works and it apply that. That often we're surprised that doesn't happen as often, that we know what works. We're searching for new things, but just the application of what we know works in real life sometimes gets you more outcomes. And then data collection, I think understanding and adopting, computer tactical aspects of this is important. I think data mining is important. I think some level of predictive modeling is critical. And then that leads to policy initiative. And that's the ultimate goal. But we do it with working around our 4 pillars, which are, you can see at the bottom, basically. So science helps move our 4 pillars forward. We have funded prematurity research centers, and you can see here the various ones from the date of their inauguration, from Stanford, Ohio, University of Pennsylvania, Chicago. We inaugurated the Imperial College in 2018, and University of California, San Francisco, and our Washington University has just finished it and ended its collaboration for 5 years. And there's various themes that are going on in terms of research at every one of them. And it's all science, remarkable, cutting edge research that is happening. I'll skip this slide because we're happy to share this. It talks about each where the focus is. They're both from basic science to all the way to environmental science and data analysis for each one of these PRCs. We also think that it's important to understand preconception health in terms of life course approach with population level interventions. We need to focus on lifestyle. We need to focus on infections, nutrition, and contraception. These are all important pieces that we are doing the work in various countries. So as an example, we held our latest international conference on birth defects and disabilities in Colombo, Sri Lanka. Thank you, Dr. Duran, for being there. It was very successful and just before the COVID. We did have, you can see the listing, previous conferences as well here. So we have a track record of running these. I will try to end there and we will be happy. I will turn it over back to you.
Thank you very much, Dr. Gupta. We now give the floor to Professor Adair for her presentation.
be talking about the implications of small size. You just heard about a lot of the reasons for prematurity, and we'll be following up on some of the long-term consequences associated with prematurity. The now very well accepted developmental origins of adult disease paradigm holds that fetal and early infant environments affect not only short-term health, but also long-term health and survival of the offspring. Unfavorable conditions in utero may affect growth and development of tissues and organs, with important implications for functional capacity, such as fewer nephrons affecting kidney function and blood pressure regulation later in life. Unfavorable conditions may also program metabolic functions and alter gene expression. Many aspects of the prenatal environment play a role, with implications for a very wide range of health consequences throughout the life course. And as you can see here by these word clouds, we have looked at a number of different types of stressors in the prenatal environment and connected them with a very wide variety of outcomes in the long run. Early developmental origins of adult disease work focused on the maternal nutritional status, but it has really expanded to include maternal stress, hypoxia, physical activity, a wide range of environmental pollutants and chemicals, as well as infant feeding, care, and morbidity, and the potentially additive or synergistic effect of these exposures. The initial focus was on fetal nutritional restriction, typically resulting from inadequate maternal diets before or during pregnancy, or to placental insufficiency. And we've learned a great deal about the long-term impacts of these types of insults from animal evidence. And we find that prenatal restriction results in reduced fetal growth and small size, and relatively larger deficits in some organs and that compared to others. And as adults, we know that these animals that are previously undernourished eat more, especially when they're given high-fat diets. They have more adipose tissue, elevated blood pressure, and abnormal glucose metabolism. But we can't do this kind of experimental study in humans. And so most of the observational studies we have really focus on looking at birth weight. So the very largest volume of DOHAD work the past 30 years has focused.
Linda, excuse me, this is Cesar. I think your first slide is stuck.
Oh.
Because I'm following the slides you shared with the group earlier, and I see you're already ahead of that.
Is it moving now?
Okay, this is fine now. Thank you.
Okay, I'm sorry. I didn't realize. I couldn't tell from my screen that this was happening. So thank you for letting me know. So most human studies relate birth weight to outcomes later in life. And with the very largest volume of studies that we have over the last 30 years have focused on birth weight. And the classic studies relate higher levels of risk factors to lower birth weight. And as you can see in the small panel on the right, in the bottom, there is an inverse association between birth weight and systolic blood pressure. And this is exemplary of a lot of the different outcomes that can be seen in this developmental origins work focusing on birth weight. So why are we so focused on birth weight? Well, it's the most widely used proxy for the quality of the early environment. It's strongly related to infant morbidity and survival. It's widely measured in nearly all clinic settings, and we know that records are widely available, providing evidence for retrospective studies. Here is an image of the midwife records that were used in David Barker and Clive Osmond's original Hertfordshire study that shows the inverse association between birth weight and adult of, cardiovascular disease mortality. The problem with birth weight, however, is that it's a very heterogeneous phenotype. It reflects both time in utero and growth rates. And we know that the lower end of the birth weight distribution includes both babies who were preterm and those who are small for gestational age. The phenotype also involves differences in body proportions at birth, reflecting probably the timing of environmental insults. The other important thing to note is that organ-specific growth and metabolic alterations that result from prenatal insults may not be manifested by size at birth. For example, some of our famine follow-up studies and experimental primate research show effects independent of birth weight. However, very few DOHAD studies have explored these different phenotypes and looked at their long-term implications. So I'd like to mention work that is done by the cohorts collaboration, and you'll hear a bit more about this from Cesar, but this study unites cohorts from 5 different low and middle income countries around the world, including Guatemala, India, the Philippines, South Africa, and Brazil. And if we look at the rates of being small for gestational age and preterm birth among low birth weight infants in these populations, you can see that there's quite a bit of variation, with the lowest prevalence of preterm birth in Delhi, the highest in South Africa. And we see that in the Indian population, a much higher percentage of low birth weight is attributable to being small for gestational age, rather than to prematurity. So this is a very important source of heterogeneity across the populations that we're studying. Ranjan Yagnik has also done very important work about birth phenotypes and adiposity. And he's described the small, thin Indian baby phenotype, where the average weight Indian baby is 20% body fat at birth compared to the white Caucasian baby, who has only 10% body fat. So he's described this as this thin fat baby as potentially a risk factor for later development of diabetes in adulthood, because we know that phenotype of reduced muscle mass and higher adiposity is a risk factor for diabetes. So if we take a look at preterm birth and long-term risk of non-communicable diseases, we find that there's a real scarcity of studies because there's a lack of reliable gestational data from a lot of the older cohorts, and in particular from low and middle income countries. And this occurs because of a lack of good dating techniques and the less than widespread use of ultrasound technology until much more recently in low and middle income countries. However, we know this is very important. As you just saw, there are very important trends towards increasing rates of preterm birth in some settings. And these in particular reflect the increase in late preterm births, that is those between 34 and 37 weeks. So on the right here, the Pelotas studies have shown a dramatic increase between 1982 and 2015 birth cohorts in the rate of preterm birth, most recently close to 14%. In 2019, there was a systematic review of adult outcomes that are associated with late preterm births. And this is an important time period because it represents the largest proportion of preterm births. And of particular interest is that of the 53 publications determined from this review, 46 of them were from Scandinavian countries and none were from low and middle income countries. This is a significant potential for bias, given that the Nordic countries have the lowest global prevalence of preterm births. But together, these studies show us that there's higher all-cause mortality, cardiometabolic risk factor levels of these biomarkers, higher type 2 diabetes, asthma, and mental health disorders, less atopic disease, but lower physical fitness, lower cognitive abilities, poorer educational attainment, and poorer occupational and income status in adulthood. It's very important, given these adult outcomes, to see where they come from. And so there are some relatively new studies that have looked at child anthropometrics and body composition. And this is important because many of the risks of poor outcomes in adulthood are associated with adiposity. And so we're very interested in the time period during which adiposity develops. As I mentioned, there's very few studies in low and middle income countries, but a number of really important studies from the Pelotas birth cohorts. And in the first, in follow-up of children that were 2, a large sample of adequate gestational age children with a prevalence of late preterm birth of 11.3% were studied. And this follow-up found that late preterm births were associated with a higher odds of underweight and stunting at age 2. So there's a quite significant elevation in the odds of both of these adverse child outcomes in the important time period of the first 1,000 days of life. This cohort was also followed up between ages 6 and 7 using DEXA to look at body composition. And what you see in the table in front of you is the fact that both males and females have lower fat mass, lower lean mass, and lower percent body fat if they were born in this time period of 34 to less than 37 weeks. So these babies are vulnerable based on their body composition and limited stores at birth, with potential long-term consequences for outcomes. These graphs show you growth in the Philippines cohort that I've been working with for now 35 years. And these are the growth rates over the first 12 months in length in the top left panel. And you can see that the preterm small for gestational babies clearly had the shortest length at birth. A fair amount of compensatory growth occurs over the first 6 months of life. And by the time they're 12 months old, the gap has narrowed substantially. In terms of their body mass index, we also see some recovery and more rapid growth in this preterm SGA group. But still, there are substantial differences in BMI at age 2. And when we look at them as adults, we find that all infants who were small for gestational age, on average, have a deficit of about 1.9 centimeters in adult height compared to those who were born adequate for gestational age. And in terms of BMI, the term small for gestational age girls actually have a 1 unit lower BMI compared to those that were born adequate for gestational age. So in this particular cohort, we see that the deficits that are present at birth are retained with some catch-up growth over time. By and large, there's strong tracking of birth size, and this is why it's so important to optimize factors that influence prenatal growth. And so in the bottom, you can see that there's tracking of height. This is Cebu males. And these are groups that are defined by their birth centiles within the sample. And you can see that the order is pretty much maintained over time. And then similarly, when we look at adult height, there's strong tracking with those that were the shortest at birth remaining the shortest in adulthood. If we look at BMI, the same thing occurs. And you can see here that these are the BMI trajectories that are observed in children in different groups of children over the first 2 years. And those patterns are maintained so that the group with the highest, fastest BMI growth had the highest adult BMI. Those in the middle stayed in the middle of the adult BMI distribution, and those that were thinnest remained in the thinnest group of adult BMIs. It's important that we consider the theory of mismatch that's been put forth by Sir Peter Gluckman and Mark Hansen. Their idea is that poor maternal diet and inadequate stores prenatally create phenotypes that might be adaptive in the short term to enhance survival of those infants that are exposed to those poor environmental conditions. However, if they're born into dietary adequacy or excess in the postnatal period, if they have high-fat diets, energy excess, sedentary behavior, there's a synergism that operates. And so this combination of prenatal restriction and postnatal excess is responsible for the increased risk of chronic disease. Our cohorts collaboration was particularly interested in studying the effects of the kinds of rapid growth that you see following undernutrition prenatally, and in places where low birth weight prevalence is quite high. So in the cohorts that you saw the map from before, we looked at adult outcomes in relation to the rapidity of growth in early life. Now there's some literature that shows us and that raises concerns about rapid growth and whether rapid growth increases risk of poor outcomes in adulthood. This is particularly of concern for low and middle income countries where we would like to see compensatory growth catch up after periods of undernutrition. And we want to know whether promoting faster growth for those infants is detrimental in the long run. So we undertook these studies to look at whether faster relative weight gain in different periods of life were related to adverse outcomes in adulthood. And here you're looking at the graphs for systolic blood pressure. And what we find is that there's a small inverse association between birth weight and adult blood pressure. During the first 24 months of life, there's only a very small elevation in the risk of having higher blood pressure later in life. But as we move into the periods into mid-childhood, and then between mid-childhood and adulthood, there's a dramatic increase in the risk of rapid weight gain in these time periods. However, rapid linear growth relative to weight gain does not confer the same risk for elevated blood pressure later in life. The same is true for glucose. And so you see here in the main line represented in black that the increased risk of having elevated glucose as an adult is only associated with more rapid growth after the mid-childhood years through adolescence and into early adulthood. And there are no risks associated with faster linear gain. So this is good news for those of us who want to see optimal growth and in terms of compensatory growth in the first 1,000 days of life. In contrast, when we look at schooling, those individuals who have faster linear growth in the first 2 years, importantly, have much higher educational attainment later in life. So the message here is that it's very important to have good linear growth early, and that it's not so risky to promote faster weight gain. There's concern about overweight and obesity being more prevalent in adults who are stunted at birth, but we do not find that that is true in our cohort samples. So with the exception of Guatemala, where the sample size is quite low, you'll see that in comparing the blue bars to the red bars in each country, you find that those who are not stunted actually have a higher percentage of obesity compared to those who were stunted. So we do not see the excess risk of obesity among previously stunted individuals in this cohort. And then we also wanted to look at, in particular, whether faster weight gain following different periods of growth restriction was more risky. So what we're looking at here is 3 different periods of malnutrition, either at birth, represented by being small for gestational age or adequate for gestational age at birth, wasting at 6 months, so poor infant nutrition in the first 6 months of life, and then stunting, representing chronic undernutrition across the first 2 years. And so what you should do here is compare the red dots and the blue dots. We're looking at the interaction of rapid weight gain in these time periods with risk of being more centrally obese in adulthood, having a higher BMI or having higher skin folds. And across the board, you'll see that there are no differences between the red and the blue dots, indicating that there is no greater risk of rapid relative weight gain following undernutrition in these samples. The only significant interaction was for stunting with more rapid growth, and we see that there's actually an inverse association. So it is not more risky for those who were stunted. It was actually less risky for those who were stunted. So in conclusion then, I'd like to summarize the key points and note some of the important areas where more research is needed. The first point is that we need to continue to recognize the heterogeneity of birth weight, both the mix of preterm and IUGR, the differences in body proportionality at birth, and the differences in relative size and function of organs at the same birth weight. Second, preterm birth increases risk for later non-communicable diseases, but most of the literature appears to show that IUGR, growth restriction, is a much more important driver of the long-term consequences compared to being preterm alone. We do, however, need more long-term follow-up of preterm births in low and middle-income countries because there is a paucity of literature in this area. Children and adults that are born preterm tend to remain shorter and thinner than those that are born at term, but we need more research to identify the relevant biological pathways through which later risk is conferred. And in particular, we know that adiposity is a common denominator for NCDs. So this apparent paradox of having relatively less body fat early, but greater risk later is one that needs more attention. We know that linear growth and BMI track strongly from birth, and this really emphasizes the importance of optimizing the prenatal environment. And that's a message that we also heard from Dr. Gupta about the importance of preventing preterm births. Our cohorts do not find increased overweight and obesity among those who were previously malnourished. So we shouldn't be afraid of trying to promote compensatory growth because it can have some benefits for child health outcomes and survival. But we do need more research on body composition and how to obtain optimal balanced growth in lean and fat tissue during periods of recovery from undernutrition, both prenatally and in early infancy. And then finally, rapid weight gain between mid-childhood and into adulthood is quite strongly related to adverse outcomes of elevated blood pressure and fasting glucose. And this emphasizes the importance of obesity prevention during the school years. So this is a critical period for us to devote resources to, in addition to the prenatal period. So with that, I would like to acknowledge my cohort's collaborators and thank you very much for your attention. Now turning over to Cesar.
Thank you, Linda. I'm going to jump straight in. It's a real pleasure to be here today because as I can remember as a medical student in the 1970s reading the PAHO publications, the CLAP publications, the work by Capurro on a simplified approach to estimating gestational age, which was widely employed in Latin America. And so I thank Suzanne, I thank Andres and Pablo for inviting me to participate here and to share some results. Also, I will build upon what Raul and Linda have presented so far in terms of their presentations. Can you see my screen? Yes?
Yes, sir. Yes.
Okay, thank you very much. So I'm going to speak about a series of papers we are working for publication in the Lancet next year. It's called the Optimizing Child Health series. And my role in that series was to participate, to lead the second paper, which is on how early life inequality and poverty affects not only child health and nutrition and development, but also adult human capital and health. So I'm going to make a brief presentation on that. And the underlying concepts are the concept of the Sustainable Development Goals, that we should leave no one behind, and that the interconnectedness of goals, that the health goals relate to the education goals and gender goals and development goals and environment goals and so on. I'm also going to speak about something that Raul has mentioned, are the social determinants, the causes of the causes. If we think preterm birth does affect long-term health and human capital, or low birth weight affects health and human capital, what determines preterm birth and what determines low birth weight? So the concept that their socioeconomic conditions are a distal determinant of many of the risk factors that we study more often. It's also the concept of social gradient in health. Is not only that we have one group that is left way behind, but also it's a continuous in the association between social position, socioeconomic position, and a lot of the health and human capital outcomes. My talk has two parts. It's quite brief, but it's basically, the first question is how important is early poverty for child adolescent health, nutrition, development? And for this purpose, I'm gonna show some analysis of recent national surveys from low and middle income countries. And then the second part is how important is early life poverty for adult health, human capital, and intergenerational outcomes. And I'm going to show you the results from the cohorts collaboration, which Linda has referred to. By the way, Linda is a co-author of our series because this is has greatly benefited from all the data that she has collected in Cebu, as well as the data from South Africa, India, and Guatemala, and Pelotas. So the outcomes, I'm not only speaking about health, but I'm trying to have a bit broader definition of what's important in life, and that it does include growth, survival, development, schooling, teenage motherhood in particular. And for adults, we're looking at health, we're looking at attained height, and we're looking at intelligence and schooling. My first part, therefore, is based on the very large database that we have here in Pelotas. We are part of the Countdown to 2030 initiative, and we're also a WHO PAHO Collaborating Center in Health Equity. We have data from over 400 surveys from 117 countries that we have been accumulating. And these data we use to produce graphs like this. This graph is known as an equiplot. It was developed by our group here. And each dot is a wealth decile. We assess wealth using household assets. So how many assets people have in their home, whether they have a radio, a TV, a motorcycle, what kind of building materials are used in the home. And then we divide society, all the households in the sample, into 10 equal size groups. You'll see a lot of analysis by wealth quintiles. And actually in the second part of my talk, I'm going to revert to wealth quintiles because of sample size issues. But the analysis by wealth deciles are really, really useful because they tend to show wider gaps, because it's very often like here. Let's look at under 5 mortality in West and Central Africa. This brown group here are the wealthiest 10% of the households. Their under 5 mortality is about 50 per thousand, whereas the poorest households, their under 5 mortality is about 130, 140. So we show huge differences here in all regions of the world. In all of them, we tend to have a monotonic increase in mortality with greater poverty. Obviously, this is not new, but it's based on a much larger sample than has been available for earlier analysis. We're talking about 83 different countries included here in these analyses. So number one finding is that children who are poor are less likely to survive. their mortality is often 2, 3, or even 4 times greater than children who are better off in the same countries. The second one is stunting. You see a very similar pattern, huge differences again. Again, if we look at West and Central Africa, we have 15% stunting in the rich compared to 50% in the poor. South Asia, huge gaps as well. Latin America has a very special situation here. I just wanted to call your attention to the difference, the gaps between consecutive deciles. And here we have that the poorest 10% is way more affected by stunting than even the next 10%. So it's a scenario of marginal exclusion in which there is a portion of the population that is being left way behind. And this is also observed in other relatively developed areas of the world, like East Asia and the Pacific, and also Eastern Europe and Central Asia. In contrast, in poorer countries, the rich tend to be the ones which are way different from everybody else. So we call this top inequality because the top of the scale, of the wealth scale, shows much better indices here. And down here, we call this bottom inequality because inequality is particularly due to the higher rates of stunting in the bottom part of the scale. So the patterns are very, very consistent. If we look for development, this is a very simple development scale, the Early Child Development Tool, which was made popular by UNICEF. And again, you see huge differences. And again, in West and Central Africa and South Asia, you see that the rich are much better off. East Asia and Pacific, the poor are worse off. In Latin America, about the 3 poorest deciles are worse off. Again, very, very consistent results indicated the importance of early poverty for not being in track for child development. Teenage motherhood, we do not want any girls to become mothers, and the gaps are huge. Even in places like Latin America, we have 10% of girls in the top decile become mothers by the age of 20, compared to 55% in the poorest quintile. Huge differences again throughout the world. And lastly, incomplete primary school. Again, there are regions of the world where just about everybody completes primary school, like Eastern Europe, East Asia, and Latin America. But again, you see the poorest being left way behind in several parts of the world. So this is the concept of teenage motherhood and incomplete primary school, they are key determinants of human capital in adulthood. Because if a girl becomes pregnant and has a baby before the age of 20, her education opportunities are limited. And this is what we are seeing here. This is much more common among the poor than rich. By the way, these are boys and girls together here in this graph. Now, the summary of my first part of my presentation, the analysis of these 83 national surveys, they're all carried out since 2010. So these are pretty recent data. We see very consistent inverse associations between poverty and outcomes that reflect health and human capital, and substantial gaps in social gradients, monotonic increases in risk as households are poorer for most outcomes. We see the widest gaps in sub-Saharan Africa. There are 2 regions, the West Africa and the East and Southern Africa, and also in South Asia. And the narrowest gaps tend to be in the previously socialist countries, which are Eastern Europe and Central Asia, where the gaps are still present, but they're not nearly as wide as in some other parts of the world. So we are seeing with this first half of my presentation that today's children, if they're born in poverty and they grow up in poverty, they have substantially poorer performance in terms of survival, in terms of nutrition, in terms of human capital. That also applies to adolescents because the teen motherhood and the primary educational indicators are measured in adolescence. Now, if we move on to adulthood, obviously we're going to have to wait a long time until we can figure out how today's inequalities are affecting the next generation of adults. But we can go back in time with the cohorts. And this is the same graph that Linda showed us. And this is also a point that she made. The area of the countries, of the geographical areas in this map is proportionate to the number of birth cohort studies that occur in these countries. The proportion of all the world's birth cohort studies that occur in Northern Europe and North America is huge. And we have very few studies from underdeveloped or low and middle income countries. And therefore, the cohorts collaboration was set up in 2006. We started with this paper in the Lancet, the 2008 paper on maternal and child undernutrition. You can see that I was the first author here and Linda was the second. So we've been working together for a very long time. The 5 cohorts are here. I just wanted to highlight some of the issues here, which are highlighted in bold here, is that some cohorts like Pelotas are all social classes. Also Cebu, the Philippine cohort that Linda runs, are all social classes as well. But Guatemala, they're all poor. There are 4 rural villages. In Delhi, they're mostly middle class. And in Bercho-20, they're Blacks and predominantly urban poor from Soweto, which is a suburb in Johannesburg. So the magnitude of what we're going to show now, the gaps between rich and poor obviously are affected by the samples that we do have. We don't expect such huge differences in Guatemala because everybody's poor, but we do expect larger differences in other cohorts where different social classes are being represented. So let's go quickly over the outcomes that we have measured. Again, I looked at teen motherhood, I looked at schooling, IQ, height, and I also looked at some of the NCD markers and risk factors, including BMI, number of metabolic signs, and psychological problems in the cohorts. If we look at adult height, and here I'm using quintiles, not deciles, because our sample size is not sufficient. You know, in every cohort, you see obviously that men are taller than women. And in most cohorts, you see a very clear social gradient here. Pelotas, Guatemala, even though they're poor, the least poor in the rural villages are taller. Delhi, a clear difference, also Cebu. So we're seeing that the difference in child height remains, that the social gradient in child height remains when these people become adults. If we look at schooling, again, very marked gradients, very clear. The number of years attended by school is as much higher in the wealthiest quintile here in the golden color than in the poorest quintile, the dark green circles. Again, very clear in all cohorts. This one is one that really strikes me. All cohorts have had, except for Delhi, have had data results on intelligence in adults. And we see a very, very clear pattern. And in places like my own city of Pelotas, the difference is about 15 points of IQ. This is a huge difference. This is a 1 standard deviation difference between rich and poor in the same city, which definitely shows how early life adversity, income inequality will be transmitted to adult life into the next generations, because if your intelligence is clearly related to income, and therefore if your brain is stunted just as your body is stunted in early life, and if you receive less intellectual stimulation in early life, then you are bound to be a less intelligent adult, and that affects your whole lifetime earnings and the health and survival and development of your children. Huge differences here, really striking. Teen motherhood, again, the patterns are not so clear. They're very clear in Pelotas, but they are not so clear in the other cohorts. Even in Cebu, there's a slightly higher prevalence of teen pregnancy in the upper classes. Delhi, some mixed findings, but again, as I said, very clear patterns in Pelotas. Psychological symptoms, we use the SRQ test in all the cohorts, not very consistent. In some places, the men are a higher risk, the poor men have more psychological symptoms. In other places, we have the reverse pattern, so not so consistent. In overweight, very interesting results, and actually in many places, the better off have higher prevalence of overweight and obesity, which is the case, for example, in Cebu, which is the case for men in Pelotas in the both cohorts. Also, it's the case for Soweto men. It's very consistent with what Linda said early on, that we do not find that stunted kids become more obese. It's actually the overweight kids in early life that remain overweight and obese throughout life. And this is my last result slide. The metabolic signs, again, a very complex pattern, no clear differences, no clear social patterns. I think it's important to report not only on the things that turn out to be what one might expect to be, that early poverty is associated with worse outcomes, but also the whole complex association between early life determinants and non-communicable disease outcomes in adulthood is also complex, and often it's a higher socioeconomic strata that are more affected. So summing up the results, the early poverty was significantly associated with shorter height, lower IQ, lower schooling, and with teen motherhood, at least in the Pelotas cohorts. There is strong evidence for a social gradient in health. That is, the early poverty, exposure to early poverty will result in poorer health and human capital in adulthood. But we had variable results for overweight and obesity, and some different results for men and women in some cohorts, variable results for metabolic syndrome and for psychological symptoms. Also, the strongest associations were in Pelotas. Pelotas had a much larger sample size than the other cohorts, but also it's a society that deeply stratified in terms of income, as is the case for all of Brazilian society. Now, I would, if I was giving this talk prior to COVID, I would end here and I would say poverty is being reduced throughout the world. These are data, pre-COVID data, but we now know that COVID is disproportionately affecting the earnings and income and the livelihood of the poorest. So that we're going to have many, many more people jumping back into poverty now that we had this terrible pandemic that is affecting all of us. I have been involved in doing research in COVID in Brazil. This is a survey we're doing in 133 cities throughout the country. Each wave of data collection, we do antibody tests on 33,000 people. So it's a huge sample size, one of the largest serological COVID studies in the world. And when I just look at the kids in my survey, this is what I get. Prevalence in the poorest kids is about 3%. Prevalence in the richest kid is just over 1%. So I am afraid that COVID, we all know that COVID is disproportionately affecting ethnic minorities, Blacks, indigenous populations in Brazil, but it's also affecting poor children more than rich children. We're not sure what the long-term effects will be, but just like most conditions that we see, there's a social gradient that favors those who are better off. So to wrap up, I think the survey analysis I presented in the first half of my presentation confirmed the importance of early poverty for child and adolescent outcomes. The birth cohort analysis suggests that these effects are lifelong, and human capital of tomorrow's adults will be affected because today's children will become tomorrow's adults. And present inequalities in child outcomes are likely to affect health and human capital in the next decades if things continue as they are. The literature on child and adolescent health and nutrition has been largely focused on proximate determinants and on biomedical interventions, which are really important. I'm not trying to detract from that. And the cohorts work have shown how much how important birth weight is, how important prematurity is, and how important it is to have biomedical interventions about these conditions. But also, it calls our attention for the need for broad anti-poverty and multi-sectoral agendas, which will complement and amplify the benefits of biomedical interventions. And now we're talking about conditional cash transfers, minimum wage, child benefits, universal health care, parental leave, and so on. And in face of the pandemic, action against the social determinants of health has become even more important. Thank you very much.
Muchas gracias, colegas. Excelentes. Las tres presentaciones realmente han sido muy interesantes y tenemos algunos minutos y algunas preguntas que los participantes nos han hecho llegar a través del chat. Vamos entonces a compartir con ustedes las preguntas. Han sido recogidas en el orden en que se dieron las presentaciones, de modo que voy a comenzar y voy a leer a continuación una de otra las preguntas al doctor Gupta en primer lugar. La voy a leer en inglés porque así están formuladas. Question from Dr. Ortigosa. Dr. Gupta, have you considered among these determinants also the levels of intervention? Like, for example, how we target interventions in urban versus rural areas? The second question, also for Dr. Gupta, from Carla Berdichevsky, is, Dr. Gupta, could you kindly reflect upon the possible effect of under-registration of preterm birth and death on the country maps you presented?
Thank you, Pablo. For the first one, yes, it's very important to consider the urban and rural. When I showed you the map of the United States with maternity care deserts, we have found that a third, 35% of the deserts where there is no OB care and no OB hospital is in urban areas, in metropolitan areas. So we know that the deserts are there in not only in rural areas, but also in urban areas. So the interactions have to be focused on that. For example, in rural areas, the issues are one of transportation. The ability, if a woman is there, she has to take time off, she has to find daycare for her other children, and she has to drive somewhere else. So the question then becomes is, can you look at telehealth? Can you get broadband? Can you look at digital ways? Can you look at intermediate healthcare providers like doulas or midwives in a team effort to be able to address the problem? So in urban areas, it might be the transportation could be solved by having a local, when you're developing your bus route, you make sure the bus route cuts through in urban planning that area, so it becomes easier for that person, and especially low socioeconomic income category, to be able to travel to the doctor. So the challenges are different, and we've just only talked about transportation, but same thing goes with, there could be food deserts, there could be access to care, there could be, so all of these aspects differ in some ways between urban and rural, and they will have different policy implications as well as programming. But on the other hand, they're also similar, because at the end of the day, the outcome is the same, whether it's maternal mortality, preterm birth, and other aspects, it's the same outcome. So we have to, if we start to address the inequities, I think we then go and find the levels of intervention that we need, both in urban and rural areas, to be able to solve, and some level of control we need to give to local communities in order to develop their own solutions. Pablo, could you please repeat the second question, please, again? I'm sorry. Pablo, the second question, if you could repeat, I would appreciate. I think it had to do with some interventions, but I'm just got the second question.
Raul, this is Cesar here. I think Pablo's having technical issues. The second question was on under-registration of preterm births, partly explaining the patterns you observed.
Thank you, Cesar. Clearly, this is one of the reasons that as countries especially are moving from low middle income to middle income, we need to extraordinary focus on developing the infrastructure around them. We often think about developing a network similar to a CDC or an FDA. We also have to think about developing registration systems in those nations that are able to capture, because of course, when we don't address what we don't see, and we don't see what we don't capture. So I think it's very critical for us to have a better levels of registration and capturing that information across the world. And in 21st century, we do have technology solutions. So anyone and any place that there is a cell phone, there's no reason that we should not be able to have literally a real-time ability to register those births and to be able to classify those births. Now, there has been a lot of work done through the global burden of disease. And I can tell you, as one of the researchers and co-authors of that work, but there's constant work that is very encouraging on a sub-national level that is happening at a district and a county level. So we are getting better data than we did even 5 or 10 years ago, but we also have a long way to go to ensure. So the registrations are part of a system that actually then develops to capture all of this information around birth. That also then goes back to capture information around pregnancy and then pre-pregnancy. And if we do this right, we should be able to capture the life course of individuals, but then also reduce their risk factors. So sometimes technology would be not only to capture preterm birth, which are underrepresented currently, but also ways to address it. Thank you for that question.
Muchas gracias, doctor Gupta. Ahora voy a combinar dos preguntas para la...
Now combine two questions for Professor Adair. Given the importance of pre-birth and post-birth conditions that you have mentioned, how do you believe from the public policy perspective that this should be focused to prevent the impact you have mentioned? And another similar question, how do you believe that the COVID pandemic will impact the situation in the next few years?
Access to the translation and don't speak Spanish, so I don't know what you just said.
I'm sorry, I'm going to express the questions in English. So these two questions are similar. The question is, based on what you mentioned about the prenatal and postnatal conditions and the impact in the life course, how do you think that the public policy should address these challenges? And the second one is related to the potential impact of the pandemic due to COVID-19 and in which way it can affect the prenatal and postnatal growth.
Okay, well, taking the second question, I think we need to learn a lot more about the prenatal effects of the pandemic. But one of the mechanisms from my perspective in nutrition is that we do see some increases in food insecurity and alterations in healthcare in response to people being afraid to go to their prenatal care visits, to obtain immunizations for their children, et cetera. So I think that the long-term impact on child health is going to be very important given these effects on just maternal stress, food security, et cetera. So that's going to need a lot more attention, and I certainly don't have any good answers at this point. In terms of the interaction of pre and postnatal for policy, there is a lot of controversy in the literature around rapid growth and whether or not we should be promoting rapid growth or recovery. I think it's important that we recognize that it is important for children to catch up, but we really need to devote attention to optimizing that catch-up growth so that we don't overshoot. So it's certainly important. I mean, Cesar, for example, has found differences in morbidity and mortality of children who catch up from prenatal undernutrition. And they do need to catch up, but we need to be very careful in optimizing their growth and making sure as they get older that we're not allowing excess growth and adiposity. We really need to find out what promotes good linear growth, because stunting is still a key public health problem in many low and middle income countries. So I think we need to crack the problem of stunting, and this will go a long way to help us understand better the long-term consequences of these early environments. Perhaps, Cesar, you have other inputs on that question with respect to COVID, because I have less experience in that area.
Yes, I just turned on my video because I think that we have to think about three different issues. Number one is COVID is more likely to affect poor children than rich children, because they live in crowded households in poor areas where social distancing, hand hygiene, and so on is difficult. So that's number one. COVID may have direct effects on development that we still don't know. It's all very new. Number two, COVID is affecting the livelihoods of their families. The poor families are much more affected by rich families. So today's children growing up in poor families will face lack of adequate nutrition, lack of schooling as well, which is very important, and so on. And thirdly, COVID is really disrupting health services. In Brazil, our own study documented a 20% drop in vaccination rates because of COVID. People were afraid to take their kids to a health facility because there would be COVID cases around. So I think we still have a long way to understand how COVID will affect this, but it will certainly make things worse than they were prior to the pandemic, when, as Andres said in his very initial presentation, when things in Latin America for kids, as stunting was being reduced, mortality was dropping, things were getting better overall. But now I'm really afraid that they will become worse, at least in the near future. Thank you.
Thank you, Linda. Thank you, Cesar. And I'm going to ask a question to Cesar related to what you have just mentioned. You stressed the biomedical interventions. Do you think that there is not enough visibility of these conditions at the public policy? And this is related to another question that says, how do you see the link between health, education, and social networks in the different countries of the region in terms of respond to this situation that you presented?
Thank you, Pablo. No, I think we definitely need the biomedical interventions. We need the vaccines. We need the antenatal care. We need the antibiotics for treating childhood illnesses and so on. The issue is that we also need to think about the broader multi-sectoral interventions that are needed in order to address the social determinants of health. And for that reason, it's not a either or situation, but we need both. And the second question relates to intersectoral action, to the interface between health and education and social interventions, such as those that I mentioned earlier. There's a lot of discussion now in Brazil about a minimum income policy in which everybody, whether they are entitled to receive child benefits and so on, or whether the government would guarantee a minimum income. Obviously, it's a very political discussion, but I think that there has been a movement in many countries towards that, moving from the conditional cash transfer programs to limited population groups to a broader anti-poverty agenda. The example that I really like to discuss is Peru. Peru had 30% stunting year after year until about 2005 or 2006. And then there was a broad anti-poverty agenda. And actually, the interesting thing is that stunting was one of the indicators for measuring how effective the agenda was. So it's a poverty agenda, interventions in different sections, but the outcome was stunting. And within a few years, they have reduced the stunting prevalence from 30% to just over 10%, as far as I know, the most recent data. So it's really important to involve other sectors. The health sector can only go so far, and as long as we involve other sectors, that's what is key to ensuring that children grow up in a healthy environment and they become productive adults who actually fulfill their biological potential to contribute to society. Thank you.
Excelente, muchísimas gracias. Ya estamos en horario.
We're already on the dot. We've met the end of the schedule, but we went beyond reaching our expectations in listening to how the topics have been covered and with the participation of everyone. Dr. De Francisco had to go to another meeting, and therefore I'd like to turn the floor now to Dr. Cerrulla for the final words. Thank you very much, everyone. I'd like to thank you all, and particularly
Han sido tres excelentes presentaciones y creo que han dado.
And I believe that you've given us an outstanding view that has led us to think about the future. This webinar that thinks about the future years of CLAP after 50 years of contributions has proven that we have a long way to go, a lot to do. Implications that might seem individual are part of our social capital. So thank you to each and every one of you, those who've been our speakers this morning, those who are present. And I'd like to express my special gratitude to our regional advisor on neonatal health, Dr. Pablo Duran, and the CLAP communicator, Ana Tigas, who've coordinated the efforts for this meeting. Ana Artigas and Pablo. CLAP has celebrated 50 years of work in order to bring evidence to show the best technical cooperation and in order to establish essentially interdisciplinary work and intersectoral work. We've seen this in all the presentations, and more than ever, partnerships are essential so that we can de facto achieve the commitments that we have in the indicators, development indicators, the SDGs indicators in the development achievements, but also in keeping with the indicators in each country. So thank you very much to each and every one of you. So we bring this webinar and to an end, and we'll meet on November 4th when we will have the second webinar celebrating the 50 years of CLAP. And we will be discussing something that has already been presented here, which is teenage pregnancy. All that we have to say, all that we have to discuss about that currently. Thank you very much.
imagino que todas las madres y los niños van a tener una posibilidad mucho mayor de ejercer los derechos que tanto proponemos y deseamos. Que los embarazos sean deseados y planificados en virtud de lo que venimos trabajando, que va a haber una importante reducción en la mortalidad de causa prevenible. En ese sentido, en ese vínculo y diálogo entre la evidencia científica y la generación de políticas, creo que el CLAP es donde ha tenido y va a seguir teniendo una incidencia muy importante.
O grande desafio seria ter para 2030 alcançar não somente no promédio do país, mas também ao interior de cada país, em cada província, em cada estado, para cada grupo poblacional, ter a mortalidade materna por debaixo de 35. Isso eu creio que seria logro muito importante para a saúde e a qualidade de vida da região. O compromisso político dos governos, com a participação das sociedades, das comunidades e com a cooperação técnica, com todas as ferramentas técnicas que temos para apoiar esse processo.
La vocación de CLAP es cuidar. Lo que nosotros decimos durante 50 años, y queremos hacer mucho más, es cuidar a las mujeres y a los recién nacidos. ¿Y cómo se cuida bien? El cuidado va desde la promoción hasta la vigilancia y a la atención de la salud. Se cuida bien con buenas prácticas, con humanización de la atención y con el uso de la innovación tecnológica. Es a eso que nos dedicamos hoy y los días futuros lo pedirán, que seamos cada vez más innovativos, pero que siempre pongamos en primer lugar la atención humana a cada una de nuestras mujeres y recién nacidos.
Com pedrinhas de brilhante, para o meu amor passar. Se eu roubei seu coração, é porque tu roubaste o meu também. Se eu roubei teu coração, é porque te quero